Paraneoplastic symptoms associated with renal cell carcinoma, RCC, are clinical syndromes caused by the indirect effects of the tumor, typically due to substances secreted by the tumor or by the body's immune response to the cancer. These symptoms are not directly related to the physical effects of the primary tumor or its metastases. In RCC, paraneoplastic syndromes are relatively common and can affect multiple organ systems. Below is a detailed explanation. Endocrinologic syndromes. These are the most frequent paraneoplastic manifestations in RCC due to the tumor's secretion of various hormones and hormone-like substances. A. Hypercalcemia. Cause: ectopic secretion of parathyroid hormone-related peptide, PTHrP, prostaglandins, or cytokines like IL-1 and TNF. Symptoms: fatigue, muscle weakness, nausea, vomiting, confusion, and polyuria. Frequency: occurs in approximately 10 to 20% of RCC cases. B. Hypertension. Cause: increased production of renin by the tumor. Symptoms: headaches, vision problems, and cardiovascular strain. C. Polycythemia. Cause: overproduction of erythropoietin, EPO, by the tumor. Symptoms: increased red blood cell count, leading to headaches, dizziness, and thrombotic events. Frequency seen up to 5% of RCC patients. D. Cushing's syndrome. Cause: ectopic production of adrenocorticotropic hormone, ACTH or ACH-like substances. Symptoms: weight gain, moon face, abdominal striae, hypertension, and muscle weakness. E. Hyperprolactinemia. Cause: tumor secretion of prolactin or prolactin-like substances. Symptoms: galactorrhea, amenorrhea, or infertility. Hematologic syndromes. These occur due to the tumor's impact on bone marrow function or production of hematopoietic factors. A. Anemia. Cause: chronic inflammation, cytokine release, or disruption of erythropoiesis. Symptoms: fatigue, pallor, and shortness of breath. Frequency common in RCC. B. Thrombocytosis. Cause: tumor secretion of interleukin-6, IL-6, stimulating thrombopoiesis. Symptoms: increased risk of thrombotic events. Leukemoid reaction. Cause: excessive production of granulocyte colony stimulating factor, GCSF, by the tumor. Symptoms: high white blood cell counts resembling leukemia. ASH3, neurologic syndromes. These syndromes are rare but significant and result from autoimmune or metabolic disturbances triggered by the tumor. A. Paraneoplastic encephalomyelitis or cerebellar degeneration. Cause: autoimmune response against neural antigens shared with the tumor. Symptoms: confusion, ataxia, nystagmus, and cognitive dysfunction. B. Lambert-Eaton myasthenic syndrome. Cause: autoimmune attack on voltage-gated calcium channels at the neuromuscular junction. Symptoms: proximal muscle weakness, dry mouth, and autonomic dysfunction. 4. Dermatologic syndromes. These may result from cytokine release or immune-mediated mechanisms. A. Stauffer syndrome. Cause: non-metastatic liver dysfunction due to cytokine release, e.g. IL-6. Symptoms: elevated liver enzymes, hepatosplenomegaly, and jaundice. Frequency seen in about 3 to 20% of RCC patients. 5. Other miscellaneous syndromes. A. Fever. Release of pyrogens like IL-1, IL-6, or TNF by the tumor. Symptoms: night sweats, chills, and fatigue. B. Weight loss and cachexia. Cause: tumor-induced release of inflammatory cytokines, e.g. TNF-α, IL-6, and metabolic alterations. Symptoms: severe weight loss, muscle wasting, and anorexia. Prognosis. Paraneoplastic symptoms often indicate an advanced disease stage, though some, like polycythemia, can be seen in localized RCC. Diagnostic challenges. Symptoms can mimic other systemic conditions, leading to delayed diagnosis of RCC. Management. Treating the underlying RCC often resolves these syndromes. Supportive therapies like managing hypercalcemia, controlling hypertension, or correcting anemia may also be required. By recognizing these syndromes, clinicians can expedite RCC diagnosis and improve patient outcomes.